So my name is Eric Erb. I did my medical school and residency in Dayton, Ohio at Wright State, and my fellowship in adult reconstruction at Mississippi Sports Medicine in Jackson, Mississippi. Currently employed at Orthopedic Specialists in Sports Medicine in Granville, Ohio, where I focus on hip and knee replacements. And today we'll talk a little bit about some common knee injuries that we see in athletes in sports. So first, I'll get into ACL injuries. One of the more significant knee injuries that we see, the ACL, or the anterior cruciate ligament, is one of the most common ligaments that provides stability to the knee. Located in the front of the knee, it connects the lateral or the outside part of the knee of the femur to the front of the tibia. And it is important for the athlete when they're performing any cutting or twisting motions during sport. Therefore, we see these injuries happen in sports that have more cutting or twisting motions. So football, basketball, soccer, things like that. An athlete is most at risk of injuring their ACL when they're turning or twisting on a planted foot. So if that foot gets stuck on a turf or trapped on the ground from another player pinning it into place, it greatly increases the force through the ACL and can increase the risk of that ACL tearing. These can also be seen commonly as non-contact injuries. So if you ever noticed a knee of an athlete kind of buckle inwards in the position, that's the position the knee falls when the ACL tears. These are more common in female athletes. Women have a wider pelvis, so it increases the angle of force that is translated through the knee and puts more stress on the ACL during these cutting and twisting motions. Females also have a more narrow femoral notch. So if you can see this little notch where the ACL lives right here on this picture over there, that is a little bit more narrow in women, increases the risk of them injuring the ACL. Not all ACL injuries result in a complete tear. They can be sprained, remain intact. And if that's the case, they don't always require surgery. But an ACL tear does have a very, very low chance of healing on its own, and in that case, often requires surgery. So symptoms for these, people generally feel or hear a large pop when an ACL is torn at the time of the injury. And it's associated with immediate instability, pain, difficulty weight bearing, and significant swelling. So that's a big red flag. If you ever notice significant swelling right after the injury, that would be a concern for an ACL tear. And the best next step to do is to get an MRI to confirm the injury. From the surgical side of things, there are a variety of ways a surgeon can reconstruct the ACL, either with the patient's own patellar tendon, quadriceps tendon, hamstring tendon. Choice of graft really depends on the surgeon and their experience with different ways of harvesting that tendon. You can also use allograft cadaver tissue, but that's really only used in older patients, 40, 50 or up, because there have been some evidence that has shown there's a higher re-tear rate in those patients, in younger patients when an allograft tendon is used. The decision to perform surgery on this injury is based more on the patient as opposed to the injury. You can still perform inline movements with an ACL tear. So you can still jog, go up and down stairs. People living their day-to-day lives wouldn't necessarily notice not having an ACL. But any cutting, any twisting or turning, anyone trying to get back to their sport essentially needs a surgery for this. So the only people who could potentially get by without needing surgery is older recreational athletes, and that kind of is the reason to hang it up. However, I will say a chronic ACL deficient knee will have inherently less stability and can buckle easier than one with an ACL, and it increases your risk of other knee injuries such as meniscus tears or progression to arthritis. And so in younger athletes, continuing to play on this without getting a surgery really increases the risk of further injuring the knee. The last point I'll make is that physical therapy is very important pre and post-operatively for these patients. If we don't work, we work on getting full range of motion in the knee prior to an ACL reconstruction. The associated swelling in the knee from the injury decreases your ability to fully flex and extend your knee. If you don't get that corrected prior to the surgery, you can end up getting a stiff knee after surgery, which in and of itself is a problem. So we generally work with physical therapy to get you fully flexing and extending your knee prior to the surgery. And then there's a very important post-op protocol working with physical therapy to get you back to full strength and full motion after this reconstruction, which generally takes around 9 months, although it is patient dependent. Second injury I'll discuss is a meniscus tear, probably one of the more common injuries that we see in the knee. So each knee contains two menisci, one on the medial or the inside part of the knee, one on the lateral or the outside part of the knee. They consist of fibroelastic cartilage, but they essentially function as shock absorbers. So during activity, during exercise, the knee can experience 6 to 8 times, sometimes more, the force of your body weight through the knee. So the meniscus helps to disperse these forces. While it is important in stability, it's not as important as the ACL, but it does function as a secondary stabilizer to provide some stability to the knee as well. The menisci do not have a great blood supply, and the closer you get to the inner border of the meniscus, the worse the blood supply gets, which essentially means they have a poor healing potential and they're not necessarily going to heal on their own if we don't correct it with a surgical procedure. There's a couple different ways to classify meniscus injuries. Degenerative meniscus injuries aren't necessarily associated with sport. It's something that happens in older people and our wear and tear injuries over time. The acute meniscus injuries are the ones more commonly seen in athletes when there's a single moment in time when an athlete notices an injury after a fall or a twist. So those we define as acute. They also are classified based on the type of tear that occurs. So you can see that image up on the top right portion of the screen, looking at different types of tears. They can be associated with what we refer to as mechanical symptoms. So popping, clicking, catching. The type of tear that happens will determine the best course of treatment moving forward, as some of these tears are handled differently during surgery. So, for example, there's a specific type of tear, the one you can see in the middle on the bottom there called a bucket handle meniscus tear, where the displaced cuff of meniscus can actually displaces into the middle of the knee and physically prevents full extension of the knee because it gets mechanically interlocked in the notch and prevents you from fully extending the knee. So in that case, surgery is always indicated in order to get you moving again. Not all meniscus tears require surgery, but in a young athlete with an acute injury experiencing these mechanical symptoms, that is one that should go to surgery to get it checked out. Whether or not you're repairing it or just cleaning it up, again, the type of tear will determine what the best case moving forward in the surgery is. But without even going in and cleaning it up, sometimes those injuries can extend and become a bigger problem than they need to be. Generally, after a repair where you're putting a suture anchor or some type of fixation device through a meniscus injury, most surgeons will limit weight bearing for about 6 weeks after surgery, and return to sport isn't for about 4 to 6 months. Third injury I'll discuss is the MCL. So the MCL is the medial collateral ligament located on the inside or the medial side of the knee. Another commonly injured structure, actually probably the most injured ligament in the knee in athletes. It provides side-to-side stability. So it's at risk for being injured when a lateral force or direct force to the outside of the knee is applied on a leg whose foot is planted in the ground. And that's the reason why you see so many offensive linemen wearing knee braces, because they serve as a protective measure to protect their knees if they were to get rolled up on the side of the knee during a game. This knee is associated with pain on the medial or inside portion of the knee and instability with side-to-side motion of the knee. More common in males, when the MCL is torn, it usually occurs at the attachment to the femur, so at this top portion up here, as opposed to its attachment onto the tibia. And the only reason why I mention that is because when you have an injury to the MCL off of its femoral origin, there's a lower chance that you're going to need to undergo surgery from an issue like that as opposed to when it gets torn off of the tibia. Again, most of these are treated non-operatively, so it's rare that you're going to operate on something like this. Usually you just give it 2 to 4 weeks of rest, depending on the severity of the injury, along with a hinged knee brace to provide some support while the injured tissue scars in. For more severe injuries, an MRI can be warranted. So here's an example of one of those MRIs, and you can see right about here is that disruption of that black band on the medial side of the knee, which is representing the MCL. Again, not common to require surgery for this injury, but if there is a complete tear with continued significant instability, sometimes a repair or a reconstruction is required. And last, I'll talk about one insidious injury. So IT band syndrome, a bit more chronic as opposed to the previous 3 that I talked about. The IT band is a fibrous band of fascia located over the lateral side of the knee. So you can see that issue right here. It is actually an extension of a muscle on the lateral side of the thigh that extends up past the outside of the hip. And the issue with the IT band is located over a little bony prominence on the outside of the femur called the lateral epicondyle. And so as you flex and extend your knee, the IT band snaps back and forth over that little bump, which can cause inflammation and swelling of the tissue. And when the tissue swells, it's going to become more of a problem as it continues to snap back and forth over this with any type of flexion and extension. So this causes inflammation and then irritation and pain with activity. So it ends up getting worse with people that are trying to work through it without appropriately addressing it. More often seen in runners and cyclists because they're athletes that are continually, repetitively flexing and extending the leg. So risk factors for this syndrome can be athletes who have a tight IT band at baseline, or pain, people that suddenly increase their activity level or training intensity as opposed to gradually building it up over a period of time. Generally, these are also treated non-operatively. It is rare to have to operate on something like this. First line of therapy is to rest, and the hard part is to rest long enough to get this to calm down. This is similar to a lateral epicondylitis of the elbow, anti-inflammatories, and activity modification. So not common to have to do surgery for this. Therapy is a strong part of the treatment strategy for this. Specifically, exercises working on abductor muscles of the hip, such as clamshell exercises or side leg lifts, which can help recovery. Usually takes about 4 to 8 weeks to resolve, but it can persist for months. So if it is something that is still bothering you after 4 to 8 weeks, sometimes a steroid injection can be beneficial to be a local anti-inflammatory right over the spot where it's bothering you the most. So it continue to be aggravated by continued activity if not addressed. In rare refractory cases, you can operate on this either by excising a small portion of the IT band, or lengthening it to decrease tension and decrease the amount of friction that area and that band is having over that bony protuberance, but not common.